In the next video I will show you the ligaments at the coracoid process and also assessing the supraspinatus. So when we scanned the subscapularis, we ended near the coracoid process to search for impingement. So this is also the starting point to scan the coracohumeral ligament. The coracohumeral ligament connects the coracoid process with the greater tubercle. So when looking at the subscapularis, we're also looking at the coracohumeral ligament, which can be seen right here underneath the gliding subscapularis and attaching with a broad expansion to the coracoid process. So look at this ligament for thickening and also stiffening. After having looked at the coracohumeral ligament, we're going to search for the coracoacromial ligament. So connect the transducer with the coracoid process, but also with the acromion right here. And now I'm going to show a lateral rotation, external rotation, and what we can see underneath the coracoacromial ligament is movement of the supraespinatus muscle and tendon and also the subacromial bursa. To check for impingement, you could also use other movements, for example abduction, adduction, or even if you would assess overhead athletes, you could also look in this position, a sort of a pitching movement. What we want to check at this ligament is that the ligament stays flat during the movement, this is good, and that there is no convexity or bulging up, which would mean that there is a pressure underneath. Then I'm going to turn the model a little bit and placing the arm in a modified cross position, and we're going to check the supraspinatus in transverse, and we're going to follow the fibers of the supraspinatus until their insertion to the greater tubercle and also back. Look at the tendon quality, tendon thickness, but also if you see any fluids in the subacromial subdeltoid bursa. After having checked it in transverse, we're going to rotate the transducer to longitudinal plane. And again, we're going to sweep the transducer, slide the transducer over the longitudinal supraspinatus, back and forth, so that we have a good overview over the whole tendon and overlying bursa. If you want to see the bursa laterally to the greater tubercle, so that is a wise thing, as sometimes also bursal fluids can be accumulated right there, even if the bursa on top of the supraspinatus looks healthy. So always also check laterally to the greater tubercle. Let's place the patients with the arm next to the trunk and in this position. And now what we're going to look at is the supraspinatus. The supraspinatus gliding next to the acromion during a abduction. So abduction and back to adduction. Yes, and to see whether there are signs of an impingement of this posterior supraspinatus tendon and the subacromial bursa in relation to the acromion. So you're looking for buckling of the tendon or effusion in the bursa, and this all looks healthy in this patient. So if we're going to slide the transducer more towards ventral, then at one point you will lose the acromion right here. And you will see a hyperechoic transverse coracoacromial ligament on top of the supraspinatus. And now I'm going to move again to abduction and adduction, and you will see that the bursa and the tendon is moving underneath the hyperechoic transverse ligament. This is a very good spot to look at. I see more impingement signs at this level than I will do at the acromial level. So this is definitely something which I do always in my protocol. And last technique I want to show you is the supraspinatus muscle. So if you have a large cuff tear, you will expect also a fatty infiltration. So if you want to check for fatty infiltration, you can place the transducer in transverse plane over the supraspinatus muscle. All right. Like this. And now we can see the supraspinatus muscle in between the spine of the scapula and the clavicula. and we can see the hypercoic supraespinatus aponeurosis. And looking at the muscle, I will compare the muscle with the overlaying trapezius muscle. So the echogenicity of both muscles should fairly be the same. Last test is a strength test, so I'm going to place a pressure against the patient's arm, asking for an abduction, and then looking at how the muscle fibers behave during this contraction. In the next video I'm going to show you the AC joint and also looking at the infraspinatus, teres minor and the dorsal glenohumeral joint. Patient is still seated upright, sitting on a stool, placing the transducer over the AC joint, connecting the clavicula with the acromial bone, like this. And what we will do is we're going to first check the AC joint statically, so sweeping the transducer from ventral to dorsal, looking at the bone regularity and also how the capsule thickness is and whether we see effusions. From a traumatic perspective, we can also look at joint width, the height of the clavicula in relation to the acromial bone, as if there is a huge difference, then it might indicate ligamentous injury. So after I've scanned it with the patient statically, then we're going to ask the patient to move dynamically by making a movement, a cross-arm maneuver, which is from this location to the other shoulder and then totally back. And at this location the patient needs to relax fully, and what we're going to assess is the stability of the AC joint. So do the two bones stay together? So let's do that by making this movement. Okay, so you can move your hand to the other shoulder. All right, good. And go back please to your leg, and at the end please fully relax. Okay, so we don't see any change in the bone, and that is a good thing, because with an instability you would have seen a large drop of the clavicula. Then we're going to check the infraspinatus tendon and teres minor. So we're going to rotate the model a little bit, and then I'm going to place the transducer on the insertion to the greater tubercle. And now we can see the insertion of the infraspinatus with on top of it the subacromial subdeltoid bursa, and we're going to slide the transducer to distals to also check the teres minor tendon. After we have checked this insertion, we're going to follow the tendons towards the humeral head and beyond to the musculotendinous junction right here, and even further to the posterior joint right there. Now we can see the glenohumeral capsule attached to the labrum, and that is attached to the glenoid cavity, which is the lowest bone seen in screen. Overlying is the infraspinatus muscle and the hypercoic infraspinatus tendinous aponeurosis. So let's have a look at the external-internal rotation. We look at the movement of the labrum, how that one behaves, but also for fluid accumulation in the joint capsule in the posterior recess, and see whether the labrum stays in the same spot. After having checked the labrum and the joint, we all can move a little bit further to search for the sphenoglenoid notch. Now the deepest in screen, 4 centimeters of depth, and we're going to make an external rotation to see whether we can see fluid collections accumulated around the nerve, the suprascapular nerve, and screen for a nerve entrapment. Now we can see the vein opening and closing with making this external rotation, but that's a normal finding. If you see a fluid, then this anechoic mass stays there, whether you internally or externally rotate. Then once again going to the infraspinatus tendon insertion and following in transverse view the infraspinatus to the tendon to the muscle belly right here. Now we can see the infraspinatus muscle belly, and once again what we will do is check the infraspinatus muscle search or assess the echogenicity, and we compare it with the overlying deltoid muscle. And this echogenicity should be fairly the same. You can see the internal aponeurosis very well, so this is also a sign of a healthy muscle. And we're going to ask the patient again for a contraction. So you can push there, yes, and relax. Once again, yes, and relax. Okay, so this is also a healthy muscle. In the next video, I'm going to show you how to scan the ventral shoulder in one sweep, and we're going to activate the patient so that you can also see the zone anatomy dynamically. So we're going to place the transducer in short axis plane over the intertubular groove, like this. We're going to tilt in order to make the tendon hyperechoic. And we're going to follow the long head of the biceps to distal, and we're going to observe for fluid accumulation around the tendon and also for capsular changes due to his tenosynovitis. At this level, you can see pectoralis major tendon in long axis plane, but the short axis long head of the biceps. And this is a point where the biceps is stabilized by two structures, which is the pectoralis major and also the latissimus dorsi. Well, the pectoralis major has been pointed out, it's in the middle of the screen, hyperechoic. And now if I externally rotate the arm, you can see also deep to the bone, coming from the depth, a structure which is the latissimus dorsi, and both latissimus and pectoralis is stabilizing the long head of the biceps. And this insertion we can monitor by looking at the external rotation. We're going to follow the biceps tendon down to distal, and at this point what we can see is the junction towards the muscle bellies, and now the muscle bellies can be seen beautifully. And what I always do is when looking at the biceps muscles, especially if a long head of the biceps complete tear is suspected, I'm going to ask for a contraction of the muscle to see how the muscle volume behaves and also what the echogenicity of the muscle is. Following the biceps back towards proximal, at this level what we're going to do is look at the rotator interval, and there we're going to follow the biceps and assess the relationship with the coracohumeral ligament and also the superior glenohumeral ligament, also both stabilizing the biceps tendon in the rotator interval. So I'm going to turn the model a little bit, and what I will do is I'm going to extend the arm, and with this extension I'm going to internally and externally rotate the patient's arm. And what we want to see is that the biceps follows the movement of the humeral head. And this is what's happening. So this is healthy. In an unstable situation, you will see that the biceps will move in the opposite direction. Okay, so turning the patient back, let's follow the biceps back to the intertubular groove. And now I'm going to look for stability in the intertubular groove by making an in and external rotation. And now we can see that the biceps is within the groove and is not luxating or dislocating during this external rotation, internal rotation movement. So this is also a healthy sign. Then from here on we're going to follow the subscapularis tendon. First, in 45 degrees of external rotation, I'm going to look at the insertion to the lesser tubercle. So this insertion looks fully okay, and if I'm happy with the insertion, then I'm going to externally rotate the arm towards 90 degrees of external rotation. And then I'm going to look at the full tendon from proximal, following it to distal, in order to see not only the tendon quality, but also the quality of the bone, the cortical bone, and also the overlying subacromial subdeltoid bursa. This I will do in long axis plane for the subscapularis, that's this one, but also in short axis plane like this. And I'm going to make sure that I will see every bit of the subscapularis, as it is a very large structure. I'm going to scan from medial to lateral in order to see all tendon fibers in the end inserting to the lesser tubercle. Last thing I want to show with the subscapularis is following back in longitudinal axis, longitudinal plane, the subscapularis to the coracoid process, and at that level we are going to search for a subcoracoidal impingement. So we're going to back for internal, external rotation, and now we're going to look for fluid collections that might pop up from underneath the coracoid process. And we're going to search for impingement of subscapularis and bursa at the level of the coracoid. So I'm not only going to look at this level from the bone, but also a little bit lower, where we can see now the interaction between subscapularis and coracobrachial muscle right here.